As a scientific discipline, psychology is only about 140 years old. Clinical psychology reflects perhaps the most visible way that psychological science is translated to the public. Because human behavior is unavoidably reflective of our social experiences, and because society changes so quickly, it is critical that we understand the history of our discipline. Today we will discuss the history of clinical psychology. I am Dr. Paulson, and this is Abnormal Psychology. Hello and welcome back to Abnormal Psychology. This is Dr. Daniel Paulson talking today about the history of abnormal psychology. Psychology, maybe more so than other disciplines, focuses on the history of our discipline because so much of what we do exists within the social context of the era and the culture in which we live and work. And to another degree, so much of what we do has been historically limited and is currently limited by what we are able to accomplish scientifically and the social constructs that we employ to discuss our own feelings and our own experiences, our own expectations for ourselves and others. And all of these are things that I will touch on in discussing the history of abnormal psychology, but first, I would like to touch on the goals of abnormal psychology. I have listed 3 goals: to describe, to predict, and to remediate or manipulate would be another word. Patterns of psychological distress and impairment. I will discuss these broad goals more in subsequent lectures, as these map on to the goals of any scientific discipline: to describe phenomena, to predict those phenomena, and then to manipulate the phenomena. Manipulation in abnormal psychology, of course, refers to treatment. I'm also going to present a organizing framework for how to think about the history of our discipline. Most abnormal psychology textbooks present the history of clinical psychology, history of abnormal psychology, as though it's a timeline. They tell a story, and it's a very good story at that, of how it is that we got to the current era. However, I have always found these stories to be a little disjointed, haphazard, difficult to make sense of, difficult to follow the progression of. And for so many years I went looking for a way to organize it, and then I found one, which I will present to you now. The theoretical framework I would like to start us out with is known as the Tree of Knowledge. It was proposed by Dr. Greg Henriquez, who was my own master's supervisor at James Madison University some years back. Dr. Henriquez is interested in these sweeping theories that capture or describe or characterize very large bodies of knowledge, bodies of work, and really seek to organize the way in which we work as psychologists relative to how other people work in other scientific disciplines. And this is one of those theoretical frameworks, the Tree of Knowledge. The Tree of Knowledge can be thought of as and the term Tree of Knowledge is, yes, a biblical reference for any of those of you who might have caught that. But the Tree of Knowledge is hierarchical in that it starts essentially with everything. Everything in the universe, all of it, all the energy, all the matter, all the space, all the dark matter, and all the other things that may or may not be out there. And there are some of us in the research world who seek to explain essentially everything. And those people are physical scientists, specifically in physics, to a lesser degree in chemistry. But I'm going to offer a slight revision, point of flexibility with respect to the tree of knowledge that I'm not sure that Dr. Henriquez would agree with, but it makes it work better for our purposes here, as I think you will see. And that is that faith systems also often seek to explain virtually everything in the universe. There are many faith systems, not just Christian, but others as well, who presuppose that the universe is created by God and that it is God's will that has brought forth our planet and all of the other things in this majestic solar system. And so, as a all-consuming theoretical framework, or body of theoretical frameworks rather, I'm going to suggest faith, spirituality, metaphysics as an organizing framework for some of our thinking historically and today about human suffering. Hold that thought, I'll come back to it. So, of all the things in the universe, all of the stuff, some of that stuff has special characteristics where it actually replicates itself over and over and over again. And just as my grandparents had my parents, who had me, and I have children myself, those genes have been passed on generation after generation, and each time those genes work to organize physical material that is collected in the environment and reorganize that physical material so that it can pass the genes along to the next generation, just as do all plants, all sea life, etc. And we call these things life. All the physical matter that can auto-replicate in that way, we call life, and it is studied largely by biologists. Of the things that have what we would consider to be lives, some of those things have behavior that is directed in specific ways. So, for instance, dogs living in the wild, like wolves, have a social framework of sorts. There is what we call an alpha dog, and alphas are not unique to dogs. There are lots of species that have alphas in the pack. And there's some social organization within the pack. Humans obviously have very, very complex social organization, but at a lower level, like the dogs, we can think. We can think about ourselves, our own motivations, our feelings, and obviously we do that at a much more sophisticated level than do our dog friends. But the point is that of all the things that are alive, some of those things have the capacity to think and enact deliberate behavior. And we would attribute those behaviors to something we call the mind. And minds are, of course, studied by psychologists such as myself. Then, of all the creatures that do have minds and interrelate, some have what we would consider to be culture or sociological differences that are studied by sociologists and anthropologists and others. The difference between us and dogs, of course, is that human civilizations differ widely, though with largely similar components, though dog packs tend to be very similar one to the next to the next. You might say the same for schools of fish that would differ perhaps in the type of fish and the magnitude of the school, but the actual organization of one school of a particular species of fish should be just about like the organization of other species. However, human cultures differ on metrics that are not applicable to our discussion of fish or even of dogs and other wildlife. So, of all the things that are in the universe, some of those things can replicate and they have biological characteristics. Of all the things that have biological characteristics, some of those things can think, and they have psychological characteristics. And of all the things in the universe that can think, some of those things have sociological differences. So, let's move on to the application of this framework to thinking about the history of our discipline. When presenting this on a chalkboard in a classroom, it has a particular impact, I feel, in that moving from left to right, one sees that the things we would put under theories of everything, spirituality, metaphysics, and so on the left side, those things go back to prehistory. For as long as there have been people have been imposing their beliefs about spirituality and metaphysics and so on, demons and gods and what have you, on our understanding of the world. It's as though humans are, to some degree, incapable of understanding the world without some degree of spirituality. It's simply baked into the DNA. This is part of what we are as a species. However, only more recently have humans given serious thought, academic thought, scientific thought to what we are as natural creatures. And from that has developed biology, and only more recently than that have we given serious academic thought to our consideration of ourselves as creatures that have minds, minds that can work constructively toward independently selected goals and so on. And only more recently than that have we given serious thought to thinking about ourselves as creatures that live within a society and giving serious thought to how societies can be manipulated and changed to improve those societies' capacities to meet the needs of the individuals living within the society. To you and I, it might seem fairly intuitive that a society ought to meet the needs of the individuals living within the society, but that's only because you and I have grown up in the world that we have, and we've grown up in a world that is rife with discussions on that very topic. But the reason why I feel that this is impactful is because this organization, when laid out in this way, tends to mirror that suggested by Dr. Henriquez. There are these things that have seemingly been around absolutely forever. And then there are, from an evolutionary perspective, much, much more recent adaptations, such as the social adaptation of culture. And our thinking about these varying contributing factors, these determinants of our mental health, has escalated and developed over the course of many centuries in a way that largely mirrors Henriquez's thinking about the slow evolution of these varying strata of phenomena in the universe over the course of time. Presented this way, it's a little bit difficult to talk through. These are my notes that I've got written down on a sheet of paper. I really just posted it here to show you, to try to hit home that concept of the three-dimensional, or I guess two-dimensional organization of these concepts on the page. But let's set that aside and move on to a discussion of these things by column. So I'm going to start with my first column here over on the left. It involves theories of everything, or these spiritual metaphysical explanations for why it is that we have mental health problems. So I mentioned before, as soon as there were people, or at the very least as soon as people were able to begin making things like cave paintings and statues, people began attributing varying phenomena to the presence or sometimes absence of spiritual deities. And this includes mental health problems. We've learned from archaeological records that a lot of folks around the world somehow drew the inference that abnormal behavior from this we might infer things like hallucinations and delusions, possibly also anxieties and phobias. We really don't know the extent of it, though there's good evidence that this does also include phenomena such as migraines, which we would not typically discuss under the context of abnormal psychology. That's not something that I can really treat for the most part. But the point is that around the world, inferences have been made that bad things happen inside of people's heads because there are bad spirits trapped within their heads. And who knows how they got in there, but the idea is that they have to be let out. And in response to this, the treatment was developed that we now know as trephination, drilling holes in the skull to release evil spirits. Throughout history, other strategies have also been used, including fire, drowning, and other things. Certainly, drowning someone will prevent their atypical behavior from continuing, though it is certainly not what we would consider to be a constructive intervention in the context of modern healthcare. Throughout the Middle Ages, these types of interventions continued, and depending on what civilization or what society we're looking at and during what period of time we were looking at, and also relevant to the dominant theological orientation of the population at that time, be it Muslim, Christian, something else entirely, the explanations may differ. But Satan, the devil, godlessness, sin, and a myriad of other factors have all been invoked as a strategy for explaining atypical behavior. I recently turned up in a study by some historians examining original documents from the Middle Ages that discuss perceived motivations for or perceived determinants or causes of atypical behavior during the Middle Ages. And what they found is that only 16% of the documents cited metaphysical or spiritual determinants of abnormal behavior. And all of those 16% of the documents, it might have been 11 documents out of however many, 59, whatever it was, most of those were written in a way by individuals within a context that suggested that they were being employed to advance a theological orientation. And there was no reason to believe that the authors of those did not also recognize other determinants of abnormal behavior, such as the experience of trauma, loss, depression, and a host of other health problems, which we'll speak about here in a few moments. Today, spirituality still very much is a part of mental health. We know from a lot of studies that spirituality is a determinant of good mental health across most populations. People who actively participate in religious services tend to be less depressed. They endorse fewer anxiety symptoms. They also tend to live longer for a lot of reasons. Not the least of which is that participation in religious ceremony tends to offset other behaviors, substance use, for instance, that do not serve aging quite as well as spending time acting pro-socially with others in a social environment, which is kind of a description of religious practice. There are other ways, many other ways. It's modern contemporary spiritual practice touches on mental health. One of which is that many clergy from numerous backgrounds have, in addition to whatever their ecumenical qualifications are for having their job, also have graduate level training in psychotherapy or some mental health discipline. That might be a LMHC, what we call it here in Florida. Some have PsyDs and PhDs in clinical psychology. And then there are even a few who have MDs in practice psychiatry and so on, though those are few and far between. My only point is that a lot of clergy provide very good psychotherapy, and some clergy, unfortunately, provide psychotherapy that is of lesser empirical value. That is to say that we don't have scientific evidence to demonstrate that their work advances the goal of treating DSM-5 mental health disorders. All right, so let's move on then to biological explanation. So rather than going all the way back to prehistory for this one, I'm only going back to 400 years before the birth of Jesus. And the first scholar we will cite here is a gentleman named Hippocrates. And Hippocrates believed that humors influence emotional states. And he identified some humors, yellow and black bile, and I've never been certain of what those are, though I did not go to medical school. Perhaps I would. If I had, blood and phlegm. For many centuries, we've used the words like phlegmatic to indicate certain emotional states, though I think that word is largely dropped out of use. But Hippocrates spoke about varying forms of human distress, sadness, sorrow, and anxiety in particular, and related these transient emotional states to variants in these humors, he called them, and he suggested some dietary regimens to improve the humors. 600 years later, we'll jump to a gentleman named Galen, who was genuinely brilliant. Some of Galen's physiological depictions, he drew pictures of dissected animals for academic purposes so that others can learn from his work. And some of his drawings of dissections were still used up until the Enlightenment, give or take 1300 years after his death. Galen believed that the primary determinant of human psychology was human physiology. Keep in mind, he's an anatomist. He is interested in how living creatures are constructed and how our organ systems relate to one another. These things kept him up at night. He was fascinated by these questions and studied these things throughout the course of a long life. Galen suggested many interventions for improving the quality of life, including diet and exercise. Although, I will note, he did also tinker with the idea of how psychotherapy might be used to improve outcomes. He suggested that older men in the community, those who would be considered as wise and learned, those who were old enough to be free of their own compelling there's a word for this, motivations, we'll say, in terms of lust for women and so on. He felt that these individuals would be good therapists, good advisors, good consultants for those who do suffer from depression and anxiety and similar types of experiences. Interesting guy, interesting ideas. Certainly ahead of his time, to say the least. So we're going to skip another 800 years forward to about 980 AD to Avicenna. And Avicenna is unlike a lot of these other fellows in that, first off, he's not European. He is Muslim from Persia, I believe. And Avicenna is another one who believed very much that our minds relate to our physiology, and also that he got interested in the way that we integrate sensory information and how that sensory information, through some complex, difficult to understand process inside of our minds, creates consciousness. And without sensory information, ultimately we would lack consciousness. And in this way, Avicenna came to view the human mind as a bit of a mirror. We ultimately reflect the things that we grow up with and the things that we are surrounded by. Avicenna didn't really suggest treatments that I'm aware of, though he is another interesting character in our history, and he wrote extensively, and his ideas fall very much in line with Galen's ideas and ideas that were reflected by others many, many years later. Just to highlight a quick conceptual link, these ideas raised by Galen and Avicenna about how our physiology is connected to our psychology relate very closely to ideas that were brought up by René Descartes many, many years later. René Descartes is the one who said, "I think, therefore I am." And Descartes conceptually distinguished between the mind and the body. He saw these as very separate entities. Galen and Avicenna did not. And so this idea of a human spirit or a human soul being sort of somehow independent of our physiology has been an idea that's fallen in and out of favor over the centuries. And to tell the truth, sitting here about this now, I can't say with any scientific basis exactly where my own thoughts fall. But I certainly think it's an interesting discussion. Let's move on to work that is a little bit closer to the modern age. We'll jump to 1750. There was a fellow named Mesmer, and Mesmer got the idea that we have energetics and magnetics in our body, and these energetic and magnetic influences can change over time in response to a host of factors. And as those energetics change, so too would our feelings. Mesmer developed a strategy of, well, what he explained as a strategy for manipulating those magnetics in the human body. Mesmer was eventually thrown out of Vienna, but he moved to Paris. He was thrown out of Vienna because he couldn't prove that what he was doing actually worked, and so he went to Paris and started doing the same types of things and developed a bit of a cult following there for a while. But eventually his practices there too fell under criticism from the scientific establishment. And again, Mesmer was thrown out of Paris. Nonetheless, these ideas that you can manipulate human biology and human psychology using magnetics do still persist today. There are, unfortunately, those who would sell us magnetic beds for the treatment of Alzheimer's disease that run something like $6,000. Magnets to alleviate anxiety and depression. All sorts of magnetic applications can be found on the internet. But there is no empirical basis to support these types of strategies for improving human life. And so if anyone ever tries selling you magnets to reduce your distress, unless you're trying to hold things to the fridge, you should treat those people the same way that the French and the Viennese treated Mesmer, and run them out of town, because they are not trying to do you any favors. Let's come to the 1800s. There was a notable physician named Benjamin Rush. Benjamin Rush accomplished quite a lot in American medicine. He lived and worked in Chicago. And he believed that much of human suffering could be explained by blood infections. And the intervention that he suggested was circulation of the blood. And certainly, again, there's no empirical evidence to support Benjamin Rush's ideas, but he did advance this notion in a way that is empirically testable. And in the development of a scientific discipline, that is certainly critical to scientific progress. Later in the 1920s, and obviously we're jumping a big piece of time here, but in the 1920s, Walter Freeman, among others, came up with the notion that lobotomies could somehow be used to treat psychopathology, specifically schizophrenia. Lobotomies are described a bit in your book. It's obviously a horrible practice when done in the way that Walter Freeman did. We now look at these types of prefrontal lobotomies as a byword for the uninformed, exploitative medical barbarism that we like to think is a characteristic of years gone by, though human behavior does always show up to the party, I suppose. So the theoretical basis for these prefrontal lobotomies was never really clearly established. There was a post hoc explanation that these lobotomies somehow helped people negotiate the complexity in psychiatric life that might be said to be a cause, incorrectly though, a cause of psychosis. And for some people who had these lobotomies, their problem behaviors did decline after having the lobotomies, but for many who had them, the decline in problem behaviors was accompanied by even broader adverse side effects, and there never was a justification for doing this. And it was always, at best, an abusive, inconsiderate practice. Certainly an unfortunate, dark point in our shared history. But things did get somewhat better. While we don't still do lobotomies, we do still use electroconvulsive therapy. Electroconvulsive ideas started around the 1800s, mid-1800s, as scientists began exploring electricity, trying to figure out how it works and what it does and how it can be controlled and managed, what it does to the human body and to other biological tissues. The determinant, that is the reason why channeling electricity through a human head, why the channeling of electricity through a human head would improve psychopathology, that has never been worked out. We still don't have an explanation for it. However, they identified this as a fairly workable treatment for very, very severe depression, and it is still used in that way. In the past, electroconvulsive therapy has also been used for the treatment of bipolar disorder, schizophrenia, obsessive-compulsive disorder, and a whole range of other things. But for none of those disorders does it have any benefit, though it does seem to bear some benefits for depression. Notably, a significant side effect of electroconvulsive therapy is amnesia. And typically that amnesia is temporary and it passes and the memories do come back. Although it has for a long time been a very troubling side effect for a lot of people who have had electroconvulsive therapy. So moving on to the 1950s. Through the middle of the last century, scientists began exploring pharmacology in novel and interesting and much more controlled ways than had been done in the past. This was an era when scientists had great big state and academic hospitals that they could work in. And working in a large hospital allows us to accumulate a clinic full of patients with similar types of problems. And it is in these large, diverse academic medical centers that the modern divisions that we have between fields such as radiology and oncology and ear, nose, and throat first evolved. And so through the study of pharmacology, scientists and clinicians came to recognize that some chemicals some of natural origins and some of laboratory origins seem to be useful in the manipulation of varying psychological, psychiatric symptoms. So, for instance, they sort of accidentally stumbled across some drugs that seemed to help people with depression. They stumbled across other drugs purely by accident that seemed to help the symptoms of people with schizophrenia. And through this kind of haphazard, wandering course, these scientists and clinicians developed corresponding hypotheses that these disorders must be caused by chemical imbalances. And from this, we derived what is known as the serotonin hypothesis of depression and the dopamine hypothesis of schizophrenia. So briefly, what that would mean is that schizophrenia is caused by dopamine deficiencies. Depression is caused by serotonin deficiency. And we now recognize that in both cases, these are gross overgeneralizations. However, in both cases, yes, serotonin is associated with the phenomenon of depression, and dopamine is associated with the phenomenon of schizophrenia. We'll talk about both of these and other chemical imbalance types of hypotheses and pharmacological treatments for mental health disorders throughout the course of the semester. Let's jump forward then to the 1990s when physicists and others were beginning to play around with magnetic resonance imaging in novel and exciting ways to learn more about how the brain was put together. One of the difficulties with studying the brain is that people use their brains, and you can't take a brain out of a living creature and still have them be living. There are some clever strategies for studying the relationship between neurology and cognition that have been used in living humans, but those paradigms do have their limitations. But the MRI allowed us to look at how human brains channel blood during different cognitive tasks. And MRI research allowed us to gain a lot more knowledge about how specific cognitive tasks are lateralized in the brain. That is, where the parts of the brain are that do different types of things. And so, based on this information, some researchers and clinicians again got together and figured out how to create stimulators that can be very deliberately placed for the treatment of some kinds of neurological and psychiatric disorders. So, for instance, some people with Parkinson's have been fairly effectively treated, at least for a time, with neural stimulators. Stimulators have also been experimented with in the treatment of obsessive-compulsive disorder and depression, though they are certainly not a common strategy for treating these disorders. These are, again, things that we will come back to later in the semester. So biological explanations continue to be subject of significant innovation and exploration. Through the 2000s, the Human Genome Study dramatically advanced our understanding of how the human genome relates to varying diseases such as cancer and cardiac disease, among many, many others. And we've come to understand then that our genes are one determinant of how it is, one determinant of our risk for varying mental health disorders. For instance, if an individual has two parents with schizophrenia, their probability of developing schizophrenia is 50%. and we have isolated some genes that seem to be associated with that transference of risk. There are, of course, no treatments per se for changing our genetics. There is this thing that we call CRISPR, which, as a scientist and somebody who's fundamentally very humanitarian, frankly scares me in application to human physiology. And I sincerely hope that it's never used in that way, though I'm certain that it will be. But that is one scientist's opinion, and you're certainly welcome to your own. Possibly a more productive approach will be what we call personalized healthcare, in this case personalized psychiatry. As we learn more about how human genetics relate to human diseases, we also learn how human genetics may guide the selection of particular drugs or particular therapies, although this is still an area that we are learning about, and one we will continue learning about for some time to come. Moving into the 2010s, and as we learned more and more about genetics and how they work, we've known for a long time that genes, we call it methylate, in different ways, and there are changes in our genetics over the course of our lifespans that allow different elements of our genes to express. So you may have genes to do something or another that might not be activated right now, but may become active under certain situations or after exposure to particular environmental factors. And so the moral of the story here is that we're learning quite a bit about how exposure to environmental factors in combination with genetic risk creates risk for mental health disease. And there are a few examples of this that are absolutely stinging, rather mind-blowing, in fact. I can't wait to tell you about later in the semester. So exactly how we would develop treatments around this is very difficult to visualize at this point. But we're still very much in the throes of building a working model for how to think about these types of variables. Perhaps in another 15 or 20 years, we'll have a better notion of this. And that brings us up to date on biological explanations and determinants of abnormal psychology. So now I'm going to switch to the next column on my big chart there, which is psychological explanations for abnormal behavior. So let's go to 1550. There was a fellow named Johann Weyer, I suppose is how one would say that, and Weyer believed that the mind could be imagined sort of like any other organ system. So the stomach can get sick, the liver can get sick, the skin can become sick, the eyes can become sick, and by that same token, Weyer believed that the mind could become sick. And so he developed some shrine-style installations that he hoped would advance mental health. And he also developed some of what were forerunners to contemporary community mental health programs in the environment where he lived. Kind of a temporary strategy. His efforts, I don't think that his efforts outlived his career by very long, but they did kind of create a starting point for us. So moving forward in the 1800s, your book talks a bit about Philippe Pinel and William Tuke, who were French and English respectively. And they believed that an undignified existence, free of meaningful work and without community, lead to the development of mental health problems. And so they worked to resolve that. They took people out of what would then have been described as asylums in the cities, in Paris and London respectively, and moved them to work farms. We might not think of a work farm as maybe the best treatment for severe mental illness, although if my options were to move to a lovely work farm in the south of France or in the English countryside respectively, or move to a 1800s asylum, yeah, get me a plow any day of the week. I'd be happy to move to the farm. And in fact, a lot of the people who had suffered tremendously in the asylums did get somewhat better living on the farm. And in some cases, they were released back into society again. This ultimately led to Dorothea Dix's advocacy of state hospitals, which is also discussed in your book. In the 1890s, Freud started becoming more and more productive in his writing of books, manuscripts, delivering of lectures around Vienna and other places, including the United States. And Freud had developed the convoluted notion that maladaptive use of defense mechanisms, typically related to unresolved issues of psychosexual development, are the chief determinant of abnormal psychological states. He believed that when one's psychosexual development misfires, leading to the employment of a psychological defense, that defense may or may not be productive, and in the event of an inadequate or maladaptive defense, then someone would develop depression, anxiety, schizophrenia, bipolar disorder, etc., etc. He had a hammer, albeit a convoluted hammer, and he applied it uniformly across patients. And he applied it in the context of psychoanalytic psychotherapy. He believed that therapists' interpretations of one's psychological defenses shows light on dark places, and that the patient eventually resolves these incongruities. We don't practice psychotherapy this way any longer, and Freud was a terrific storyteller, but a horrible scientist. We'll talk more about why Freud's ideas were so horrible later on, but he did actually have a few useful notions. Transference and countertransference, among some others. We'll again talk about these as we move through the semester. Let's jump to the 1940s. There were behaviorists. You might remember the names Skinner and Watson from Intro to Psychology. And there were a lot of others, Tolman, Terman, etc., who were involved with research on learning in humans and in other species as well. And they applied what they knew about learning processes to human psychopathology. And it works well with some disorders, like anxiety disorders, and it works very badly with other disorders, like schizophrenia. So you might recall the Little Albert study where John Watson exposed Little Albert, who was a boy, son of one of his employees, to a scary-sounding bell and a fuzzy white rabbit. And eventually the boy learned to fear the fuzzy white rabbit and other fuzzy white things. And these findings were very appropriately related to things like post-traumatic stress disorder, and then they served as a basis for developing interventions for those disorders. And those interventions are still what we use today, and they work quite well. Moving forward into the 1950s, Carl Rogers believed that people need support, unconditional positive regard, and genuine authenticity in their interactions with other human beings to be healthy. And so he developed something called humanistic psychotherapy. We no longer use humanistic psychotherapy as a therapeutic modality, though a lot of Carl Rogers' ideas have become part and parcel to the ways in which we interact with our patients. Again, we'll talk more about that later. But Carl Rogers' work really contrasted heavily with Sigmund Freud's work. Freud sat in an armchair around behind the back of the sofa. There was no direct eye-to-eye contact between patient and therapist in psychoanalytic psychotherapy, whereas Carl Rogers moved the armchair. Carl Rogers could see his patients, and they could see him, because that was a more authentic strategy for communication. Carl Rogers recorded his own sessions, in part because he was able to. Freud arguably might have been able to do it, but not without very significant expense. But by the 1950s, recording equipment was becoming easier to get. And Carl Rogers allowed others to really learn from his work in ways that others had not before. So from the 1980s to today, there have been a number of other advances in statistical modeling, measurement of psychological and cognitive states, developmental models, all of which suggest that human behavior is very complex, very multifactorial. And so modern interventions typically include a whole host of stuff, what we would consider to be cognitive behavioral therapy. And cognitive behavioral therapy often draws on a whole bunch of these behavioral models, learning models, cognitive models, experiential models, skills-based models, and we sort of put all that together in a way that creates a robust, comprehensive intervention that can work for a whole range of patients with presenting concerns. This is what we call cognitive behavior therapy. There are also a range of what we call third wave therapies, such as acceptance and commitment therapy and interpersonal psychotherapy. So let's wrap it up with a short discussion of sociological and cultural explanations for mental health problems. In the 1970s, there was a psychiatrist. He existed before and after the 1970s, of course, but a number of his more notable publications came out in the 70s. His name's Thomas Szasz. And Szasz argued that mental illness is a social construct used to police aberrant behavior. Write that down, commit it to memory. It's something that may very likely turn up in the future. So let me explain exactly what that means. Thomas Szasz believed that in the natural world, what we call depression is not appreciably different from what we call normal functioning. And he would say the same for anxiety. He would say the same for what we call bipolar disorder, and he would also say the same for schizophrenia. He viewed all of these as contrasting facets of human behavior, byproducts of our human nature, and as such, things that should be accepted fundamentally at face value. And he believed that we use mental illness as a strategy for compartmentalizing that behavior and the people who demonstrate that behavior so that we can put them away, so that we can protect ourselves from them. So is Thomas Szasz right? It's hard to say. I think that there are certainly instances when he has said things, when his ideas could be very applicable. Certainly, distressed parents sometimes go looking for mental health explanations for their children's troubling behavior, ADHD, autism spectrum, when in fact, often the culprit is nothing more than poor parenting behavior. Or unskilled parenting behavior might be a better way to say it. We'll leave the discussion for another day, or if you'd like to come chat with me in my office, I'd be happy to talk more about these. I think that this is an interesting discussion. But at the end of the day, and after nearly 50 years of thinking about it, it seems that Thomas Szasz is sort of like a stopped clock, and that he was occasionally right, but typically not. In the 1990s, there was a lot of effort put into adapting the social justice movement to mental health concerns. And certainly those efforts predated the 1990s and they continue today. But if I have to pin down an era when that application of effort was most noteworthy, it was probably the 1990s. And there was a lot of focus on how social marginalization produces psychological distress. And this indicates a need for public education and social reform as strategies for reducing psychological distress. So just a quick for instance, we know that schizophrenia is more common in inner city areas. We also know that schizophrenia is more common during periods of acute stress. And to put it all together, we know that populations who live in marginalized inner city populations are at greater economic and social stress for a whole number of reasons. And so the argument has been made that by better addressing the needs of inner city populations, we may find a corresponding drop in the currently escalated rates of schizophrenia that have been observed in those populations. It is probably true. All of our best science indicates that that is a realistic approach, albeit an expensive and difficult one. Moving forward into the 2000s, we have an emerging epidemic of loneliness and isolation. I am what they call a clinical geropsychologist, and I spend a lot of time with older adults and their families. And I first became aware of a growing literature on loneliness in later life before noticing corresponding literatures applying to younger populations. But currently, 40% of young adults, by some surveys, can't identify a best friend. And we consider that to be problematic and certainly something that is unusual in a historical context. Certainly the use of technology and shifting social norms in housing and socialization have some relationship with this modern epidemic of loneliness and isolation. But we haven't figured out exactly how to fix the problem. There have been revised guidelines issued for technology use among children and adolescents, and there are socialization programs for the elderly. But this is certainly a very hot topic in mental health right now, and not one that's going to go away anytime soon. So keep your eyes out for more discussion, both in class and in the media, about this very important subject matter. So I'd like to touch on just a few common misconceptions. One is that Sigmund Freud is the history of psychology or the history of psychiatry or the history of mental health. It's not true. He is a flash in the pan in some respects, in that his ideas, though still around in some form, even people who practice psychoanalytic psychotherapy currently don't do it the way that he did it. They're much, much more pragmatic. And modern psychoanalysts are receptive, growing increasingly receptive to emerging research on that sub-area of clinical practice. But Sigmund Freud, again, good storyteller, poor scientist, and a worse psychotherapist. Certainly not one that we would model ourselves on today. I spent quite a bit of time talking about biology and psychology. And psychology and neuroscience are complementary disciplines, but psychology isn't proven to be true when the constructs are found to relate to neurological behavior through neuroscience studies. So neuroscience doesn't validate or legitimize psychology, but this is a very common misconception. And the third one, and I think that this is the most important, is that psychology is a scientific discipline. By contrast to what many would believe, we are not in the humanities. We instead use theory to derive hypotheses, and then those hypotheses are explored through the scientific process. And when the results of that scientific process do not support the hypotheses, we revise the theoretical frameworks to accommodate our new learning. And that's how you know this is a science. Throughout the semester, I will point to many, many instances when we have learned things that dramatically change the way that we think about human behavior and human psychology and abnormal psychology. And all these, I think, are fascinating to the discussion of this dynamic, ever-changing area of professional research and practice.